Dr. Mohanty, early diagnosis is key, but Dr. Mohanty, when you diagnose it early, how soon and effectively should this treatment be given? What is the time frame of the treatment? Because I think that's the bigger worry right now. Because of the unavailability of this medicine, of this injection, a lot of people are concerned that what if I get black fungus? What if it gets detected also early? If there is no medicine, what will I do? There will be a delay, thus complicating the problem.
Good evening all. I completely allude to my earlier speakers, what they have opined regarding the early diagnosis and the prevalence of the so-called black fungus. It's the color black actually does not denote mucorales, as they said. Most of our colleagues would put it as zygomyces or mucorales or rhizopus species and all that. So it's about the melanin which is there in the dirty white or the light brown fungus, which is actually not black in color. The black denotes a very advanced stage of mucor, which gets rise to all this devitalized tissue, which actually turns black. Anyway, let me just add a point to where we are today and vis-a-vis last year's or the first wave. Now, across the world, the regulatory bodies have actually opined that steroids and the tocilizumab, these drugs were actually in vogue around July, August. So the first phase, the majority of the patients actually escaped the wrath of the extra use of the steroids in the first phase. And now, when we knew that all the literature and everybody has evidenced that it is of some value to save lives, so their indiscriminate use was in vogue. But I won't take that further. But talking about this fungus early diagnosis, how do we categorize? All the illnesses in our country or anywhere, we have mild, moderate, severe. So the way to diagnose is, see, the patients who needed oxygen supplementation obviously needed steroids. So if you can categorize the ones, you can see most of these patients coming out of the COVID ward, and once they're discharged, I'm perfectly all right. So they don't follow up. And add to that, you have this lockdown. So they don't go for follow-up, even on a teleconsultation with the doctor or the center of excellence where they were actually being treated. And that delay causes more immune response, which is not actually, it's negated by this fungus, which just takes an opportunity to replicate and multiply in hordes. Just one more point about the nasal mucosa. See, we've got small micro wounds which cleanses the nasal cavity and filters out unwanted structures and objects. But here, what happens, that is totally destroyed by the long stay in ICU and in the hospital. So what happens, it stagnates. So this fungus grows in an area which does not move here and there. As we say, when in ventilated rooms, what happens when the stagnation of water, you have all the vectors coming in. So similar things happen, and this fungus keeps growing. And not for the early diagnosis, as you said, it's not a swab as an outpatient department you can go, but a diagnostic nasal endoscopy probably should be the standard of care for all COVID recovered patients, at least maybe once in 2 weeks or something like that. We don't have a protocol as yet, but that will be the first site which you can take it out.
Sure.
Scans will give an idea, it's a map, but you need absolute site. So that will give an idea. It will not be black, so you do not reach the area where it's going to be black in color. So if it's discolored tissue, that's the early sign. Yeah. And along with it, you can corroborate with your heightened blood sugars and reduce. So these are the things we need to get into act. And it's a multidisciplinary team. It's not.
I think that's
everywhere. You have kidney damages happening, so you need a nephrologist interview, endocrinologist, oculoplastic surgeons, the ophthalmologist, the facial maxillary surgeons. Not to forget, very important part and parcel of the entire diagnostic criteria, which is the standard of care, is the biopsy-driven diagnosis of this histopathological diagnosis of mucor. So pathologist, microbiologist, I would name the entire hospital team, to get to the bottom of the disease. And in my experience out here, although it is
Dr. Matthew,
we've dealt with about 4 or 5. just want to tell you, it never takes a perfect course as it 1 plus 2 plus 3 plus 4. Like we have a patient tomorrow, I'm going to do, it's only isolated oculomotor palsy, and it is a COVID patient. Just imagine. Nothing else is damaged. Inside the nasal mucosa is perfect. So isolated with the microchannels, it goes and involves in different areas, nicks and crevices of the skull base, and isolated you can have those similar signs which you need to pick up and then institute very aggressive therapy.
You know, these suggestions are being made right now because availability is a problem, and it's not like suddenly these drugs are going to be available tomorrow. We just want to know from you, do you think that the stress, at least as of this moment, should be more on nipping it in the bud, trying to identify or educate people more so that they can identify those markers that it's developing or it's happening or it may happen? Dr. Mohan, would you like to take that one? Dr. Mohan?
Okay. What I would recommend from our basic clinical experience out here, just to flag off, before the pre-COVID era, also we were dealing with such kind of disease, which uncontrolled sugars, and they were having these sort of immunocompromised states in the nasal-orbit region, and limited kind of debridement, followed by a purposeful, monitored amphotericin B treatment, actually helped a lot of patients. But now the problem is multiple fold. First of all, we do not know what is the glycemic status of a patient, and they themselves do not get into the way of identifying their own symptoms and passing it as a denial that everything is all right. Outside, a small common cold, as they say, a little headache here, a little eye pain there, okay, let's take Dolo or some kind of paracetamol and take it off. So what I would suggest, and we are going to work on that on a basis in our hospital too. We are in discussion that all COVID patients who are discharged from hospital have a very purposeful monitored follow-up at least for the next 3 months. Whatever has been done, whatever way they have been treated, and including the this immunomodulators which were given, that also has reduced the immune system a little bit, and those effects together has multiplied multiple folds and giving rise to such a kind of behavioral pattern with patients who have recovered apparently. So when they are run through a kind of a triage before the surgery, before the diagnosis of COVID, the similar things can also be done after the discharge. So they can be triaged, okay, they have to go through a follow-up, a mandatory just a diagnostic endoscopy, which will give us an idea, because whatever scans, whatever x-rays you take, it will not give you the actual picture of what is happening inside the nasal cavity. And the first sign that you detect, I think the clinician will get it right, and we can institute a very aggressive therapy. And I keep telling it's a sandwich therapy. Drug, aggressive debridement surgically, and that will reduce the fungal load and the devitalized tissue for the healthy tissue to grow back, and also the fungal load also would come down. Henceforth, we will save the kidneys. Remember, all antifungal drugs have got nephrotoxicity as a very important side effect. So we shouldn't be overusing the antifungal drugs now to get another a pandemic of kidney diseases later on in the third, fourth stages. So we have to be very, very purposeful in our intent, and we need to go with a very evidence-based, individualized.
Okay.